first. We were in Utah when I was a resident. That's why I was so anyhow, we didn't know we had fun.
We didn't think John
We showed up.
He did, yeah. Everybody was there for different periods of time. Trevor, a couple of things.
Right.
So Friday night, town
Kala means the sun, by the way.
and it just,
What's that?
it's like going
Kala
back in
means the
time.
sun.
Oh, and that's the name of the dog?
One of the dogs.
Oh, you already had names. I
But
didn't.
there's a lot of very good artists there. It's
Has names.
all art community.
Yeah.
So that's definitely.
You know, there are some definite notes. We have to. The other, big dogs are doing a better job of protecting the house. Yeah, but you know what? There's one of those. It's just like having children. Anybody have children? Your children cost you less. Your children give you a cost hundreds of thousands of dollars a year. In the 20s, I want to come back and say, what's your money? Although Mike did cost us $10,000. Yeah, well, he needed a knee replacement. So to get the x-ray for his knee replacement cost us Then he went into the surgery and see him the day afterwards he has a heart rhythm problem. I'd say in dogs, when they have a heart rhythm problem, well, they must have a problem below the diaphragm. Water in humans where we think about the heart rhythm. Because they take up fluid. So they have to open them up, and of course, I got cancer. So we have to take that laparoscopy. Anyhow, we don't know. So we would never have done it. Anyhow.
What kind of cancer do you have?
Yeah, it's typical comfort animal. But just like you, well, the operative therapy, which is a waste of time, you know, they get people like synthetic here and actually she gets through stuff. It was $500.
I know where they are all of my
like, you know, their argument, well, I get a few more months.
Yeah, it's not others against time. You gotta cancel there. So they go to like tournaments.
Yeah, we've got everything in our favor, but I'm still worried. Getting out of one head. Oh, so I'm talking about CHG. Oh. I know. So you guys get that.
The one in Epidermal. Yeah.
Fractures and breaks. Where does it go?
Okay, here we go back.
Oh no.
Catherine is very alone now.
I know.
On that same topic, you guys see if people out there.
You know how you start with the knowledge, you have no experience. Then I think you're probably in general, that's some experience. Exactly. And no, but the flip side is because I got tons.
Yes.
So I have no knowledge. That's fantastic. Yeah, that's very helpful. Because I see that, I've done that. Or go on the internet.
You know, the comic.
So they're infected alive just like 2 years ago.
It's been
So Al, have you been seen it all yet? That's normal. Nope. Up until it's not even over.
I agree.
No, the guys at Stevens, the only thing that'll help their season if you guys get them out. So they're having a really market here this weekend.
3 days ago.
Nobody thinks there's any snow. 40, 60. So it's
14 inches at the bottom.
You know, they only insure how far to get up to that. It's less calculated.
Did you take out? I took some dollars too. I know what it can do for me, but I don't know how to solve it. Derivative of sine and cosine and all
Cornea site? Oh, it must be in web. I'll find out. Listen. Let's everybody go ahead and sit down. Let's get the year started. Mike, Matt, Kevin, you want to sit down? Happy New Year. Glad to see everybody back. I don't have any real announcements other than it's colder here than it is in Hawaii. Trever, Burnett, many of you don't know, and one of the reasons I actually gave him this assignment is I wanted him to come over here and introduce himself to our community, and he'll take a minute to do that. His presentation, I don't have the exact title in front of me, but it has to do with Filaggrin mutations. Trevor.
All right, my name's Trevor Burnett, as was mentioned, and I'm new to the Northwest Asthma Allergy group. I actually work in Yakima and took over that office earlier this year, and it's been great to be back here and be in Seattle, where I did some training back in 10 years ago almost, but at Virginia Mason, and I did some time in the military as a flight surgeon, and then just completed my med-peds residency at Ohio State, and then National Jewish, where I did my fellowship the last 2 years. So we moved back to Washington to be near my wife's family, and I'm glad to be here to talk with you guys this morning. So we're going to be talking about Filaggrin mutations and allergic diseases. I have no disclosures. And the objectives of today's talk will be to review the general concepts of the epidermal skin barrier and dysfunction in atopic dermatitis, to discuss the multifunctional role of Filaggrin and how it pertains to allergic skin diseases. I'm also going to review the risk of developing other allergic disorders related to Filaggrin gene defects such as food allergy and asthma, and then also present specific therapeutic strategies targeting Filaggrin deficient disease. And there's been some new publications this month that will be highlighted. So looking at the epidermal anatomy, the epidermis is only about 150 microns thick, and it's composed about 90% keratinocytes. As many of you know, it's divided into 4 specific layers: a basal layer where the cells are generated, and then they migrate through the progression of stages through the spinosus layer, the granulosum layer, and then the cornified epithelium, which is the epidermal barrier. And this is where much of the barrier is located. And as they progress through these stages, it takes about 14 days total for the progression, and then another 14 days to desquamate and for the cells to fall off. They go through a flattening, they lose their organelles, they dehydrate, they modify their lipid contents, and they become more impermeable to the kind of outside environment. This process is dependent on degradative enzymes, and much of these enzymes are located in a gene complex called the epidermal differentiation complex, and this is located in a 2.5 megabase pair of 1q21, which we'll talk about a little bit. So this barrier is really located again in the lower parts of the stratum corneum, and it's a barrier to irritants, allergens, as well as pathogens. Its structure, if you think about it, it's kind of a brick and mortar type structure. The bricks being the finalized differentiated corneocytes, which are keratinocytes, which are called corneocytes. And these are densely packed. These are the bricks of the structure. And they actually change their envelope. And the envelope becomes much more of a cornified envelope, so much more rigid envelope. And Filagrin has a significant component of this, along with other proteins such as loricrin and involucrin. Around this is the mortar, which is the lipid lamellar matrix. And this encases the corneocytes. It is composed of ceramides, cholesterol, other fatty acids. And this is kind of the prevents water loss, and as well as water soluble entry of materials coming into the skin. And then the corneodesmosomes, these are modified, kind of the rebar of the brick and mortar structure, and they actually hold the cells together. So they're linking the cells, and they're there for tensile strength and prevent shearing forces of the epidermis. And changes in any of these structures can lead to a breakdown in the barrier, lead to increased entry of materials into the skin, and then, as we are worried about, sensitization and allergic diseases. Also important in this epidermal barrier is structures called enzymes, proteases, and inhibitors. And these are all natural parts of the desquamative process. And so, as we'll learn, many of these enzymes are pH dependent, and we know about the acidic, kind of acid mantle components of the skin, and these are dependent on that pH structure to function in optimal levels. The proteases include kallikrein-related proteins such as stratum corneum chymotryptic enzyme and stratum corneum tryptic enzyme, and these are important in breaking down those corneodesmosomes and those rebar structures, and then also breaking down and desquamating the skin. There's exogenous proteases, which are produced by Staph aureus, as well as dust mites, and these are also important in kind of the pathogen-generated injury to the skin, which can occur through these proteolytic processes. Inhibitors, which are important in this process, these inhibitors block the protease effect and kind of the brakes on the system. The important one, which some may be aware of, is LECT1, which is located on the SPINK5 gene on 5q32. And this is in the granular layer of the epidermis. And SPINK5 mutations have been associated with both atopic dermatitis as well as the cause of Netherton syndrome. Another one, which is cystatin A. Cystatin A is on 3q21, and this is actually secreted in the sweat. So the sweat produces a kind of an inhibitor layer to block external exogenous proteases from again penetrating the skin and causing damage. So cystatin A is another one that mutations in this has been associated with, again, injury to the skin and kind of atopic dermatitis type pictures. The acid mantle is something that's pretty interesting, and this is it's been known for a long time that the skin pH is actually pretty low. It's 5.4 to 5.9. This is on an adult forearm. General adult skin is about this pH. And skin's optimal function depends on a pH in this general area for these enzymes to work, these proteolytic and inhibitor enzymes. And when an infant's born, the pH is actually 6.5. So it's actually a little bit higher, a little bit more alkaline than the adult pH. And it takes several weeks for this to occur, and that may account for some of the early susceptibility of infants for developing skin-related disorders. The pH, just changing the pH from 5.5 to 7.5, you'll see an increase in the function of these enzymes by about 50%. So there's really a change in their function as they go through these layers and they become exposed to different pH environments, that their enzyme productivity improves. The acid mantle has an antimicrobial effect. So not only for optimal function, but also for antimicrobial purposes. It decreases pathogenic skin colonization. It also favors adhesion of non-pathogenic bacteria, so normal colonization. And then the important part from a Filagrin standpoint is this natural moisturizing factor. And Filagrin gets proteolytic degraded, and a large part of Filagrin is histidine, and then this gets produced into trans-urocanic acid, which is actually a UV protectant. And so this acid is there and helps protect against UV rays. And then pyrrolidine 5-carboxylic or PCA acid. Again, this one also contributes to Staphylococcal aureus protection, and both of these all contribute to the acid mantle as far as the pH component. And there's other things just from degradation and cell expulsion, including sodium chloride ions, lactate, and urea, which also contribute to the acid mantle. Factors affecting the skin barrier, obviously, so the most significant of all these has been identified in the last few years, and those are Filaggrin loss of function mutations, and we'll talk about those in greater detail. There's also mutations in cell adhesion proteins, which we've discussed, expression of these protease and inhibitor proteins, those which can be affected by cytokines, and inflammatory processes can affect those, and those all can relate to different functions of the skin barrier. Then environmental factors, things like washing with soaps and detergents, which are quite alkalines. They can alter and damage the skin. They can alter the pH and, again, contribute to injury. Exogenous proteases, which we've already mentioned, both irritative proteases such as dust mites, DERP1, which also have immunologic effects with inflammation and generating the allergic kind of Th2 cell response. Staph aureus, which is superantigens, again, can alter the skin barrier as well as be infectious. And then even topical corticosteroids. So thinking about using those as a treatment, yes, they reduce inflammation, but they also contribute to thinning of this epidermal barrier. And interestingly enough, there can be a rebound after you stop those of the dermatitis because of a thinning of the skin. So again, those things can all contribute to affecting the skin function. So here's just kind of a schematic which we'll look at here. And so again, think about your bricks and mortar. The corneocytes are the kind of brownish main structures here. They're surrounded by the lipid lamellar matrix, and then the cornea desmosomes are binding those together. Important contributing factors to the natural moisturization factor and the hydration of these cells is Filaggrin and Profilaggrin, which is here, generating their byproducts, which also contribute to the lamellar matrix and the acid mantle. And then the stability of this is dependent on the balance between the inhibitors, which are these protease inhibitors like T1, cystatin A, and then these proteases here, which we've mentioned. So it's a kind of a balanced process to maintain the structure and keep that the permeability of the barrier intact. So through various genetic and environmental factors, this then breaks down. So you have, through whether Filaggrin and Profilaggrin deficiencies, you have a lack of the natural moisturization factor, a lack of hydration. The cells then dehydrate, they break down. They don't have a proper lamellar matrix to prevent entry of pathogens. Then these enzymes can get out of balance because of pH changes in the skin. The inhibitors don't function as well. The proteases kind of activity is increased. They break down the components, and you get penetration both of pathogenic as well as allergenic substances. And then this leads to the cutaneous inflammation, immune dysregulation, as well as a kind of Th2 response. And so this is the structure and function of the skin barrier that we're focusing on. So now we'll turn our discussion more to just, yes?
Are there any drugs that enhance the levels of those protease inhibitors?
There's been some that they're looking at now, and we'll talk about one of those that's been published recently. They're looking at both for Filaggrin specific ones that will increase the Filaggrin production. As far as other ones for specific protease, I haven't seen any specific publications, but I know it's kind of an ongoing process of research now that there's better understanding about this whole function here. So now we'll talk about Filaggrin. This is some of the hyperlinearity you might see in a patient with ichthyosis vulgaris, which is actually caused by Filaggrin loss of function mutations. This is a father and daughter's hands just kind of showing the hyperlinearity. Going through the history here, so Filaggrin was actually discovered in 1977. It was through protein digests of skin that showed that this filament or this protein was kind of aggregating with keratin, and so they named it filament aggregating protein, Filaggrin. In the 80s, it was associated with ichthyosis vulgaris based on protein studies and a murine model, which we'll discuss, which is a flaky tail murine model of ichthyosis vulgaris. It was really difficult to identify the actual structure because, as we'll see, Filaggrin is a very repetitive structure, and because of that repetitive nature, it was hard to sequence it. It required a lot of overlapping of PCR and a lot of kind of machinery to sequence it adequately. And so it took years until the technology was there to really be able to do this appropriately. So it was partially sequenced and then fully sequenced. And then later in 2006, it was identified with Filaggrin loss of function mutations in exon 3 as the cause of ichthyosis vulgaris, as well as associations in European studies with atopic dermatitis. So going back to the epidermal differentiation complex, again, this is an evolutionary complex thought to generate as we transition to kind of, life in an arid or dry environment, that these enzymes were kind of co-localized in this structure. And there's clusters of cornified epithelium proteins, small protein-rich proteins, as well as late cornified epithelium protein precursors. S100 calcium binding proteins, and we'll see calcium is kind of important ion for some of the function of these enzymes. And then fusion proteins, which have an S100 fusion type component, and the S100 component is important for cellular signaling as well as kind of just generating that cell signal. And Filagrin is one of these enzymes. It's a fusion protein located in this epidermal differentiation complex. And mutations in this complex have been associated with both atopic dermatitis as well as recent studies have shown that psoriasis. There's some mutations in the enzymes in this structure that may be associated with psoriasis. So Filagrin is actually a very large protein, and it's composed of 3 exons, which we'll see here. An untranslated region here in exon 1, exon 2, which is a smaller base pair region, which codes the N-terminal calcium binding or nuclear localization component of it. And then there's the huge kind of multiple Filagrin repeats. And as we'll talk about, the number of these repeats can be important for your risk of developing atopic dermatitis. And then there's a C-terminal, which they haven't yet figured out what the function of it is, but they know that if they don't have it, the Filagrin and Profilaggrin doesn't function. So it's important, but for what function, we're not quite sure yet. So again, Filagrin has multiple monomeric repeats, which we'll talk about. Looking at the processing of Filagrin, you can see here that there's a Profilaggrin component, which is, again, large 10 to 12 repeats. And the breakdown of the Profilaggrin to Filagrin is dependent on several enzymes. Some of these are listed here. Aspartic protease, which is a skin-specific retroviral-like protease. It cleaves Profilaggrin into Filagrin, which is here. LECT1, which we've already mentioned. So the inhibition is important for the proper timing of the Profilaggrin processing. And if you don't have the correct inhibition, you don't have correct protein processing, and you have abnormalities in the epidermal barrier again, which we've talked about. More recently, caspase-14 has been identified as being important for the cleavage of Filagrin in producing the amino acid products, which are, again, part of the natural moisturization factor. And mutations in caspase-14 have been associated with a more mild form of atopic dermatitis, and which is with xerosis and UV sensitivity, again, because if you don't produce the PCA, which is one of those protecting acidic products of Filagrin breakdown, again, you can have UV sensitivity. And caspase-14 kind of dimerizes as well, and it gets generated kind of at the same time as the Filagrin, so the timing of it is appropriate in the cell, producing appropriate structures at the right time. So copy number variation. This is an interesting part of it because, again, each one of us has different numbers of Filagrin mutation, or Filagrin, not mutations, but Filagrin numbers that are in our code. And so it's either 10, 11, or 12 Filagrin repeats, and these are variable. And you can see the frequency in an Irish population, 33% had 10 repeats, 51 had 11, and 14.6% had 12 repeats. With the shortest genotype, being the 10-10 genotype, had an increased risk of atopic dermatitis of 1.6. So there's kind of a dose dependent. So just the amount of Filagrin that you have without even having a mutation, that if you don't have enough of the repeats, you can have an increased risk of dermatitis without even having any mutations. And so this is interesting just to note, because again, if you can design drugs or things like that to increase production, you may be able to affect people's atopic dermatitis by affecting their inherent amount of Filagrin which they have, not just by generating the increased production. So modest increases may make a big difference in therapeutic strategies. And here's just a schematic showing those number of repeats, 10, 11, and 12. Typically, it's number 8 or number 10 that is repeated, which is the variability between different haplotypes. So looking at specific Filagrin mutations, the original 2 that were identified were this R501X and the 2282 deletion 4. And these were identified in Scottish and Irish populations. Now there's been over 47 mutations identified. They are, as we'll see, they're ethno-specific, being that the Asian populations may have a different group of mutations that are more prevalent versus the Northern European mutations. And all of these mutations have been found to create a nonsense or a frame shift mutation, which results in a truncated Profilaggrin or Filagrin protein, which then is not translated and leads to a deficiency. And 10% of European ancestry are heterozygous carriers. So fairly frequent deficiencies, as we've noted. Top here, you can see the mutations that are listed based on European variants. Kind of bottom here, with the Asian variants. The two that are most commonly identified here are located up in this first Filagrin repeat. And again, this is a different schematic showing the same ethnospecific variation. Again, 2 mutations in the European population account for 80% of those mutations, versus Asian Pacific populations. There's over 8 genes that account for over 80%. And again, just showing there's multiple variations, multiple mutations, and it seems to co-localize based on ethnospecific variations. So Filagrin is associated with immune dysregulation. So it's important, as we've discussed, in barrier defects, because it enhances, deficiencies enhance both allergen as well as pathogen exposure, activating both innate and adaptive immunity. This results in increasing antigen presentation to APCs, disrupted keratinocytes release immune adjuvants, such as we'll talk about cytokines that also promote the inflammatory process. And this leads through sensitization through Th2 cell response. And again, production of these interleukin 4, 5, and 13 has been shown to downregulate Filagrin expression. So just by nature of the inflammatory process, then you get further downregulation of Filagrin, again, kind of perpetuating the cycle, leading to continued inflammation. So looking at cytokine profiles, so things that are important in the inflammatory process and have been affected by or affect the Filagrin function. So IL-1, which is an important initial inflammatory cytokine, keratinocytes produce this constitutively. They produce high levels of IL-1 alpha, and with inflammation, they also produce IL-1 beta and IL-18. Cleavage of IL-1 cytokines is optimal, again, at a specific pH, so an alkaline pH. So as you have damage to that lamellar matrix, you lose the moisturization factor, you have a pH change in the skin. The amount of inflammation increases somewhat because you lose that acidic nature of the skin, which then makes the production of these enzymes increase because the pH changes. Atopic dermatitis associated with Filagrin mutations have increased IL-1 alpha, increased IL-1 beta, IL-18, as well as IL-1 receptor antagonists, and this results in increased inflammation. And Keswick has shown this in this recent publication that IL-1 levels are inversely correlated with the level of natural moisturization factor, meaning that as that moisturization factor is decreased, IL-1 production is increased. And this all is affected somewhat through the inflammasome, the NLRP, inflammasome, and caspase-1 activity. Those can be accentuated by house dust mite exposure, that stimulates the release of the IL-1 beta, IL-18, and again, this can trigger atopic dermatitis. Other cytokines, TSLP has been shown to be important in this process. It's highly expressed in the epidermis of atopic dermatitis patients, and it's increased in Filagrin knockdown conditions. So again, some of the cytokine profiles are altered in Filagrin deficiencies. IL-33, which is produced by mast cells, and is important in IgE activation. This is also upregulated in Filagrin deficient mice and has been associated with asthma and atopic dermatitis. IL-25, which is expressed in epithelial cells and is important in the Th2 process, inhibits Filagrin synthesis. IL-22, which again is also important, is downregulated in Filagrin expression, or downregulates Filagrin expression at mRNA and protein levels. So again, multiple cytokines that we can see affected here. IL-17, one of the final ones that I'll discuss, it's increased in atopic dermatitis and Th17 cells. It's chronically present in skin inflammation and enhanced by Staph aureus or allergen exposure. IL-17 alpha inhibits profilagrin mRNA and Filagrin protein expression, and this may affect other components of the epidermal barrier. So just as we think about all these cytokine changes, and we think about as we move into the specific diseases, again, Filagrin is localized in the skin, but the cytokine milieu, cytokine changes that are altered may be part of the process that's causing asthmatic inflammation or contributing to food allergy generation, even though it's a skin-specific protein that we're talking about.
Trevor, I think I lost you here on one point. What is the mechanism or the distinct mechanism by which Filaggrin mutations lead to upregulation of these specific cytokines?
So some of it is because the generation of these cytokines are dependent on pH dependency of the enzymes. So as Filagrin deficiencies alter the pH of the skin, so the acid mantle, then these enzymes will have different pH dependent changes in their production. So some of it's that, so just the degradation, and then Some of it is because of the inflammation that occurs. It's kind of what comes first, chicken or the egg, but as the inflammation process begins, enzymes then have an inhibitory effect and downregulating filaggrin expression. So it's kind of a linked process, both based on pH dependency as well as kind of once the enzymes are generated, they then inhibit filaggrin production, inhibit further the deficiency that's there. So, and all of these cytokines then can systemically lead to maybe more distant inflammation or processes that may generate or contribute to asthma and things like that we'll talk about again as we go forward. So kind of summarizing here the multifunctional role in maintaining the optimal skin barrier. So you have profilaggrin. Profilaggrin has specific things such as keratinocyte calcium signaling, main constituent of keratohyalin granules, which is in the stratum granulosum, and then enucleation leads to during cornification. It's important in that process. This is then broken down to filaggrin, and filaggrin has specific important roles in aggregation of intermediate filaments, as well as contributing to stratum corneum structure and function, and inhibiting transepidermal water loss. And then the breakdown products of filaggrin producing amino acids are important in the corneum, stratum corneum hydration, photoprotective and immunomodulation of the skin surface, anti-staphylococcal effects, as well as keratinocyte calcium signaling again, which is important in the signaling through the skin. So now we're going to move from filaggrin to its effects in specific allergic diseases. So the first one we'll obviously talk about is atopic dermatitis. And so filaggrin mutations have strongly been associated with atopic dermatitis, and this was first noted in a kind of a multiple cohorts in the Irish-Scottish Danish populations, published by Palmer in 2006. And this was the original publication. They had a family, about 15 Irish families, that showed a semi-dominant inheritance with high penetrance of the null mutation. And the two specific mutations which they noted were the R501X and the 2282 deletion 4, which were studied. The carrier frequency in the European population, this carrier frequency was about 9.6% in the pediatric population, and it increased to 15% in patients with atopic dermatitis and asthma. Now, atopic dermatitis and filaggrin mutation had an odds ratio in this population of 2.6. And further meta-analyses done later in 2009, looking at about 25 different publications, showed that the pooled odds ratio in this 2009 publication was 3.2. In a separate meta-analysis in the same year, again looking at about 25 different publications, the pooled odds ratio was 4.7. And interestingly, in hospital-based cases, so the patients we see in our clinics, so the ones that are referred to hospital clinics, their odds ratio having a filaggrin-associated mutation was 7. So in more severe cases, more persistent cases, maybe a higher association with filaggrin mutation. So some additional factors. This is another publication looking at the time to onset of atopic dermatitis in kind of the first 7 years of life. And filaggrin mutations were associated with an earlier onset, so increased risk in the first year of life. And this is even further made worse with cat exposure. So cat exposure in that first year of life increased the onset or earlier timing onset of atopic dermatitis in patients with filaggrin mutations. And then looking at other environmental factors, another author looked at in a German population, odds ratios for that may also contribute to it, and having an elder sibling in the home. So patients with filaggrin mutations had elder siblings in the home. They were more likely to have, again, an earlier onset of atopic dermatitis. And so, and this is, I got to highlight my son here as the elder sibling in my house. He's a goofy kid, but anyway, so looking at distinct phenotypes of atopic dermatitis. So this is a publication looking at a Danish population, and they looked at 390 patients, of which 43% had atopic dermatitis. There was filaggrin mutations in 26 of those patients for a carrier rate of about 15.3%. And looking at characteristics, they found that patients with the filaggrin mutation, in addition to having atopic dermatitis in the other areas that are common, they seem to have more cheek involvement and dorsal involvement of the hands. They had more widespread dermatitis, so not only those lesions, but lesions just all over, more unscheduled visits to their physicians, more severe symptom scores, as well as a younger age of onset. And all of these are kind of what we think about with filaggrin mutations being the more persistent disease, higher incidence of skin infection, including herpes, as well as a greater risk of multiple allergies and asthma. So again, as we think about which of our patients might be Filagrin, or have associated Filagrin mutations, you can kind of hopefully think about some of the phenotype which may be a little bit different.
I know you're speaking loud, but speak a little louder. People are complaining all the truck noise outside.
Okay.
It's supposed to be mics all over the room here, but I don't know how effective the one in front of you.
Am I not talking into this?
Pull it a little closer and talk a little louder.
Okay. So as I look at, all right. So that's the atopic dermatitis picture. The asthma picture is much more complex.
Can I go back to one question here? What happened to the idea that having an older sibling or having a pet protected you from atopic disease?
Well, I think so. Yeah, so I think this was in Filagrin specific to patients.
Yeah.
So I don't know if it, yeah, you think that, I think that's why they looked at it, to see if it carried over. And for some reason, they thought it would be protective in both cases. I think the authors were surprised that they didn't see that maintained, because that's what we do typically think about.
I'll follow up Len's question. With the cat exposure data, they must look at dogs too? Because
dogs were actually protective. So yeah, so dogs were actually
Same as us.
yeah. So dogs were actually protective in that. So there, I think the odds ratio was like 0.47. So it actually was a little bit protective to having dogs in the home compared to cats. And if anybody has any questions, please interrupt me. I tend to be a fast talker when I do this, so please feel free to interrupt. Filaggrin and asthma. So this is much more of a complex association. Original data, again, looking at Palmer's data from 2006. 76 of the patients with Filaggrin null mutations had atopic dermatitis versus 46% without. Carrier frequency in this population of asthmatics with atopic dermatitis was about 23%. So again, think about 10% in the general population. Filaggrin mutation carrier rate in asthmatics with atopic dermatitis was much higher. And the odds ratio for asthma in general is 1.7. So some of these graphs which they had shown here, I think were kind of telling. So general population, the Filaggrin null carrier frequency is shown here. In the general population, it was about 10%. In asthmatics, just all asthmatics, it was about 15, 16%. And then in asthmatics with atopic dermatitis, again, it was much higher, around 23% for the carrier rate of the Filaggrin null mutation. It's kind of a complicated schematic because they have different comparisons that are looking at here. But in the three here, you can see the rate of asthma with atopic dermatitis, and asthma without atopic dermatitis compared to the general population, and the odds ratio of association with Filaggrin null mutations. So asthma in general, again, about 1.7 with atopic dermatitis increases to around 2.73. And then what we know is that without atopic dermatitis, there is no significant increased risk. So the asthma, again, a complicated association, but in Filaggrin null mutations without atopic, or in Filaggrin null mutations, asthma, it's not associated with asthma without atopic dermatitis. So there's that specific inflammatory process in the skin it's important in that association.
When you say carrier frequency, that means asymptomatic individuals carrying one gene. You have to be homozygous to really have significant disease associated.
Yeah, definitely. The homozygous have more severe disease, but heterozygous carriers, so just having one null mutation, so the frequency of having that just one null mutation is about 23%. So all I guess, including all either heterozygous or homozygous mutations, is about 23% in general in the asthmatic population. About 7 to 10% in the general population of a Northern European kind of group of cohort.
You still have the disease, though, if you have one gene for it, though. It's just not as bad.
It's not as bad, and not all patients have it. So probably about 50%, I think, has been shown that, because it's a complicated process, environmental as well as genetic. Your risk is much higher of having the disease, but not everybody with a Filaggrin mutation will have atopic dermatitis. But your risk is much higher. So looking from those initial publications, a German follow-up study, which looked at 3,000 pediatric patients, their combined carrier frequency was about 7%. Their odds ratio for asthma, similar, 1.7. And again, this was limited to patients with a history of atopic dermatitis. And without that association, there was no link between asthma and Filaggrin mutations. And this has been borne out, and again, in meta-analyses looking at those variable odds ratios with or without atopic dermatitis. So in general, asthma 1.4, asthma with atopic dermatitis much more associated with odds ratio of 3.2. But then in asthmatics without atopic dermatitis, no increased risk of having a Filagrin associated mutation in the general population. So overall, asthma is a much more complex association than with atopic dermatitis, and the mechanism of that is still not well known. It may be related to cytokine production, because Filagrin is not in the respiratory epithelium. It's just in the stratified corneum that we find Filagrin production. Allergic sensitization is likely an important factor in contributing to the distal effects of these Filagrin mutations and leading to the perpetuated, inflammation that may be related with asthma and other allergic disorders. Among atopic dermatitis patients, Filagrin null mutations increase the risk of having asthma compared to those without mutations. And among asthmatics that have Filagrin mutations, they have a more difficult course and more frequent exacerbations compared to their non-Filagrin associated mutation patients. Any questions on asthma before we move on to food allergy? Okay. So this is a model of a murine model called the flaky tail model, which is Filagrin deficient mouse, and it's analogous to ichthyosis and ichthyosis vulgaris murine model. And they looked at what happened with topical ovalbumin exposure in this publication in 2009, which led to cutaneous inflammation. And this led to allergen priming as well as specific antibody response. And they noted that there was ovalbumin-specific IgG, IgE, as well as Th2, Th1, Treg, and Th17 response, which was increased compared to their normal mouse comparisons with this ovalbumin exposure. And this resulted in epidermal water loss, which was increased after sensitization. So again, looking at what happens with exposure, food exposure, and how that contributes to increased water loss and perpetuating the skin disease. This was a model looking at that in a mouse model. Now, there's only been a couple studies done in looking at incidence of the prevalence of food allergy in association with Filagrin mutations. And this is one in 2011 done by Brown, and this looks at a case control study of 71 European patients with peanut allergy on oral food challenge. And they also did a replication data of 390 Canadian patients who had some food challenge, but mostly skin tests and specific IgE. And the odds ratio for food allergy associated with Filagrin mutations was 5.3. So for specific peanut allergy, this is comparing patients with food allergy proven peanut allergy versus a non-peanut sensitized control. And kind of as we look at these two numbers, it's important to know this control group, because this was a non-peanut sensitized control group. This one in the Canadian study, or the Canadian comparative study, which only has an odds ratio of 1.9. Again, this is the pediatric cohort here, but their control group was an adult cohort with unknown peanut sensitization. So there may be some variation in this, how strong these associations are, because the control group was quite a bit different compared to their initial main group here. But still, it bears out that peanut allergy had an increased association with Filagrin mutations when numbers ranged from 5.3 in the European group to 1.9 in the Canadian group. And the residual odds ratio, so when they accounted for atopic dermatitis, so just like we looked at it in asthma, and you accounted for atopic dermatitis, the association fell. It didn't fall in here. So the peanut allergic patients still had a risk, or Filagrin mutation, null mutations had a risk of peanut allergy with an odds ratio of 3.8, even accounting for atopic dermatitis. So is this association, is it sensitization, or is it also allergy? And so this was a study done in 2012 looking at an Australian cohort, again, with food allergy confirmed by skin test, oral food challenge. They looked at 700 white infants were included, in the carrier rate, again, around 10-11% in this patient population. So these groups here, looking at the odds ratios, negative control, any food sensitization, and they did skin testing, so they screened these patients for any sort of food allergy, the 5 most common ones. Once they found some sort of positive result, they brought them back in and did the skin testing and oral challenges, and to confirm it. They compared it to normal control, the normal control pediatric patients, Any degree of food sensitization was here. Food sensitized but tolerant is here, and then food sensitized but allergic. And as they compared, all these are compared to the negative control. You can see the odds ratio varied from 3 to 5 with an association with Filaggrin null mutations. It then asked the question of, does Filaggrin mutations increase your risk of having allergy above just sensitization? And so that's the comparison here. So looking at the food sensitized but tolerant versus the food sensitized but allergic, and there was no significant increased risk of having allergy above sensitization related to a Filaggrin null mutation. So kind of interesting that in this study, just showing that Filaggrin mutation did increase your risk of food sensitization, but that didn't carry over, at least in this study, to suggest that you're more food allergic with a Filaggrin null mutation.
Is there Filaggrin in oral mucosa or GI mucosa? You stated it's not in respiratory, so I mean, what's the rationale here? You have a deficient oral mucosa?
For the food sensitization?
Well, in general, but I mean, I would assume the reason you become sensitized is your GI tract is more permeable.
Right. So, so again, looking back at the kind of this mirroring model, the skin sensitization, again, abnormal processing of food proteins through the skin then leads to sensitization, regardless of the GI tract, because there's not Filaggrin in the GI tract or the respiratory epithelium. So
the idea here is airborne sensitization or
contact, cutaneous or through the skin.
What have they looked at with regard to Filaggrin deficiency and affecting on the microbiome?
So Filaggrin is important in the colonization of the skin and the antimicrobial effects of the skin's kind of protection. So they have seen that patients with Filaggrin mutations do have an increased colonization of Staph aureus compared to non-Filaggrin mutations, and that's with atopic dermatitis that they have an increased. So some of the similar stuff we see in atopic dermatitis in general, but that's accentuated a little bit in Filaggrin mutations because of the deficient antimicrobial effects of the skin barrier.
Because there's this recent PNAS paper where they showed that children born in families that had a dog where the dog was present at birth, the dog changed the gut flora of the children. There was a much less decrease in allergic disorders in children that had dogs. So I was just wondering if maybe that could be a systemic thing, if your Filaggrin deficiency in the skin somehow changing your whole microbiome,
I think there probably is some. I don't think we quite know fully yet, but there is probably some relation to that altered microbiome. It's just as we see in the gut, alterations of microbiome in the gut affect rates of food allergy. So it may be that some of those altered microbiomes and that symbiotic kind of homeostatic skin relationship then increases your risk. The inflammatory machinery that's started up and they get exposed through cutaneous exposure, that misprocessing of proteins then leads to some sort of food sensitization. And so I think that's how it's occurring through the skin, is that you have these inflammatory processes and food exposure through skin contact possibly that may contribute to that. So that's it for food allergy, and we'll kind of talk about allergic rhinitis. So a German publication again in 2008 showed that Filaggrin mutation again was only present in the squamous nasal epithelium but not in the transitional or respiratory epithelium. The odds ratio of having allergic rhinitis was about 2.6 and adjusted for atopic dermatitis was still there about 1.9. And a meta-analysis again looking in 2009 showed that allergic sensitization, so the increased risk of having any sort of aeroallergen sensitization was 1.5. And then with allergic rhinitis and without atopic dermatitis, there was about a 1.7 odds ratio, and then with atopic dermatitis, it increased to 2.8. So again, the skin is important in all of these other allergic issues. That if there's inflammation in the skin, if there's an atopic phenotype, atopic dermatitis phenotype, then their risk of having the other associated allergic disease is increased, whether it be asthma, food allergy, atopic or allergic rhinitis. That skin inflammation is important, I think, in that process. Only for asthma, though, has it been shown that that is completely only associated with that risk. All these other conditions, even if without atopic dermatitis, you still have a risk of allergic rhinitis and food allergy, independent of atopic dermatitis. So this is kind of a summary here, looking at the various diseases and their associated risk factors with Filaggrin mutations. So Filaggrin null mutations are causal in ichthyosis vulgaris, as well as a modifier in these other genetic skin disorders. For atopic dermatitis, the meta-analysis odds ratio is 3.1. For eczema herpeticum, it was 10. For irritant contact dermatitis, there's also been associations with a risk of 1.9. For asthma, as we've talked about, that risk is dependent or more likely associated with when it's asthma with atopic dermatitis, and without atopic dermatitis, there is no significant increased association with asthma and Filaggrin null mutations. Even contact allergy with nickel allergy, peanut allergy, we talked about with the risk of odds ratio of 5.3 from that one study, and then a modifier in alopecia. And this is kind of just a schematic here showing those same things with the same kind of rates of association between Filaggrin and the various specific disorders. So therapeutic strategies, just to finish up.
Before we move on to that, we got two questions from, I think, Chuck Jackson here. Do individual Filaggrin gene mutations occur in all the multiple copies of the gene? Otherwise, you would expect a protective effect from multiple non-mutated copies.
So they can occur in any one of the repeats, any one of the copies. And what's been shown is that any mutation in those copies has resulted in a truncated protein. So no matter where it occurs in the repeats, because you lose the profilaggrin, you lose that profilaggrin product. So you don't get the profilaggrin molecule that then gets on the keratohyalin granules, which are in the stratum granulosum. So yes, you have a deficiency in any sort of those repeated mutations because that truncates the profilaggrin molecule. Even though you have maybe other repeats that weren't mutated ahead of that, you get a truncated molecule, you can't process it. So you don't have the C terminus or the N terminus that's needed for the generation of Filaggrin.
So one bad copy is enough?
Is enough.
Clinical. And the other question is, do genetic mutations explain the clinical impression that atopic dermatitis is more prevalent and severe in Asian children?
Can you say that again? Sorry.
Question is, he has the clinical impression that atopic dermatitis is more severe and prevalent in Asians than other races, and does the Filaggrin story explain that?
So the carrier rate is about the same, 10 to 15, about 7 to 10%, regardless of the ethnospecific variation. So I can't say that it's any increased. I can't contribute that association specifically to Filaggrin mutations because the carrier rate doesn't change much. But in patients with severe disease, they are more likely to have a Filaggrin mutation. But I think that's regardless of whether it's Asian or Caucasian.
Along that same line, is there a decreased incidence of atopic dermatitis in blacks?
I don't know that. Sure.
Because all your study populations are all sort of Northern European or Oriental, and yet I very rarely see blacks with atopic dermatitis, and I just wondered if there's some protective gene mechanism there.
Yeah, I didn't see anything in the studies about that, specifically related to that, and maybe more information out there I just didn't get a chance to review. So,
just anecdote, but I saw a girl yesterday, a black girl with terrible atopic dermatitis. So it certainly can occur, but I don't have any idea. I guess no one studied the gene frequency.
Yeah.
Does vitamin D have any effect on Filaggrin?
I didn't see anything on that. Yeah, I didn't see anything about vitamin D associated with Filaggrin. As far as production of machinery, I didn't see that. No. So looking at therapeutic strategies, so some things that we do or already do, obviously restoring the epidermal barrier is very important. That can occur through hydration therapy, wet wrap therapy, restoration of the lipid envelope with ceramide replacement or ceramide products, restoration of the acid mantle therapy. And there's been some studies that looking at use of alpha hydroxy acids, again through pH-dependent protein. Enzyme activity. So if you can restore the acid mantle to the normal acid mantle pH of around 5.5 to 6, you increase ceramide production by about 300%. This was shown with reduced transepithelial water loss and reduced skin sensitivity. Again, so maybe these products might be useful. Again, judicious topical steroid use because of the thinning of the skin, which can, even though reducing inflammation, may then lead to a rebound after stopping. And then conservative use of soaps. And I just included this slide here, or this table from this dermatology publication in 2013, showing the pH of some common products here. And I was surprised by some of them as far as how alkaline and some of these soaps were. Again, what we use and what our patients may use, again, may contribute to the damaging nature and skin irritation just from what they're using on their skin. The final few slides will look at targeted Filagrin therapy. And this is a publication from this month from Jackie. And this group, the goal of this is to look at things that can upregulate Filagrin in deficient patients. So they screened 1,120 kind of bioactive molecules, a library of these bioactive molecules, looking for ones that may accentuate Filagrin or promote Filagrin production in this immortalized human keratinocyte line. They then, once they identified those molecules, they then cultured cells, these normal humanized epidermal keratinocytes. They cultured cells with these bioactive molecules. And one of the ones which they identified is this JTC801, which interestingly, I think, because it doesn't make total sense, is a non-peptinogenic OLR1 receptor antagonist. And it's really important in nociception, or pain reception in the skin, and is signaling in that process. And so it's implicated in inflammation and pain in the skin. It's found on keratinocytes, and it contributes to leukotriene B production, which may contribute to pruritus, which has been shown in mice. And this JTC801 has been shown to attenuate pain and sensitivity, but its exact role in Filagrin production and expression is independent of this nociceptive receptor. And so they're not quite sure exactly how it works, but as you'll see in the data that it did increase Filagrin production. So these are kind of busy slides, and we'll take you through them. But the first here, so this is looking at Filagrin mRNA production. You have the first here is calcium. So culturing these cells, in calcium, which again, looking at the S100 proteins, which are important in the cell kind of signaling, a calcium solution is why I think they use the high calcium. The JTC801 and the scriptate, which was another of their screened molecules they found had some effect on Filagrin production. So you can see that the JTC801 increased, which like my pointer here. So this third column here compared to cell culture without any of these, calcium is the second one, the JTC801, and then the scriptate. So there was increased in Filagrin mRNA relative compared to the baseline. Filagrin activity, again, JTC801 at day 1 and day 3. You see here that at day 3, the JTC801 improved relative Filagrin activity compared to culturing without any of these molecules. Calcium did it by itself. The scriptate effect dropped off. Down here, looking at, again, Filagrin activity, and they're looking at inhibition, this bottom column here, IL-4 and IL-13. So the inhibitory effects of Th2 cytokines and what it did to this process. So again, the JTC801 here, you see, and IL-4, IL-13 here, that they inhibited Filagrin activity, just so that, again, showing you that Th2 inflammation, cytokine production inhibits Filagrin activity. And when they co-cultured these, again, you can see that the calcium JTC801 co-culture here had a significant increase in Filagrin production, and that was attenuated by Th2 inflammatory cytokines, IL-4 and IL-13. This just shows the appearance of the skin here, the control in the top left, high calcium here, and JTC801, which is hard to appreciate, but maybe some improvement. These top ones here just looked at different skin-specific enzymes related to kind of the barrier mechanism, just showing that the JTC801 was specific to Filagrin. So the effect of increasing the amount of mRNA, Filagrin mRNA, it did not affect these other proteins, the Ki67, Loricrin, K10, and TGM1. So those other proteins in the skin were not affected in the same way. So kind of a Filagrin-specific therapy. This is just a dose response increase in Filagrin production. So you can see here that the Filagrin, this is a Western blot, that the Filagrin amount was increased with, it was kind of in the middle dose response area here.
Now, are these are normal keratinocytes?
These are human keratinocytes.
Normal.
Yeah.
If you took diseased ones, you just get more synthesis of diseased Filagrin, though. So is that of any benefit?
Yeah, I don't know yet. I don't know if that's been, yeah. So this is in trying to find, they don't know yet. They're trying to see if that would make a difference. But you are seeing some increased Filagrin production. And, yeah, because you may just improve.
Yeah, just make
More
more
bad
disease.
Filaggrin doesn't help you.
Yeah, these are normal human keratinocytes. And then this is just looks at a staining of the Filagrin production. So this is the mouse model then. Again, what you would probably, because those are normal keratinocytes, they took a mouse model with not a Filagrin deficient mouse, but a atopic dermatitis mouse model. So again, not a deficient mouse. So again, this may be limited data, but looking at the deficient mouse, so in heterozygous here, you can see that. And so this is interesting here because what you're talking about. So in the heterozygote here, Filagrin production was increased. In the homozygote, it was not. So if it was a Filagrin deficient, it may not improve. And it just shows the increased Filagrin in these two slides here. That skin conductance, transepidermal water loss were significantly improved with increased Filagrin production, and then clinical scores of these mice, left being the control without the JTC 801, and the right being the one with. You can see a clinical score improvement in their skin disorder. So in summary, Filagrin mutations are common single gene defects associated with allergic disease. Carriers have an increased risk of atopic dermatitis, asthma, allergic rhinitis, peanut allergy and contact allergy, and allergic sensitization. Mutations result in truncated protein and have ethnospecific clustering. And then current and future therapeutic strategies may target Filagrin-specific treatments. Okay. That's it.
So who's testing for Filaggrin? Measurement.
Yeah, and that was, I don't know anybody that is, and I don't know when or where you would. I mean,
So in Denver, for patients who come in for more complex management, do you screen all patients or some patients?
we didn't. We didn't. I mean, it was really just kind of, if it was research, obviously, then we would screen for it, but we weren't looking for it in every patient that came in with severe disease. I think it's kind of presumed that it's there, because what are you going to do with it? I think the information there's not much to do with it.
The time I looked into it, it was cost prohibitive, and I just lost interest.
Yeah.
It's kind of a parallel universe where there's not much on the practical side.
Yeah. Yeah, and I didn't find any.
There could be evil spirits in the stratum corneum, and I wouldn't know either.
Yeah.
You went through the multifunctional role of the optimal barrier, and you had 3 functions, and it says calcium channel signaling is important in at least 2 out of 3. Has anybody tried calcium blockers in a cream form on the skin to see what that does to transmitting signals?
So I haven't seen that. Looking at the data from just the normalized keratinocyte, when they cultured them in calcium, if you probably blocked calcium, I don't know if it would make it worse or not, because I think calcium is required for those enzymes to function appropriately. So I haven't seen anything when they looked at calcium blockers in the skin and therapeutic uses of that. But I'm sure there's probably something along those lines that may be therapeutically beneficial.
The thought that the one mutated copy is actually doing something harmful or interfering with the normal copy, or is it just a dose dependent?
I think it comes back to a dose dependency. So you again, even in the non-mutated individuals with the number of copies, you reduce the amount of Filagrin and you have an increased risk of atopic dermatitis. You have a deficiency even in a haploinsufficient, and that's a whole gene that's not transcribed and reduced production. So I think it is probably a dose-dependent effect. I don't know for sure.
You don't have a difference with the copies. You don't have more.
You still have 2 copies.
Just the copies. It repeats within the copy.
It repeats within those copies. So the whole gene is the multiple repeats, and it's processed into the individual Filagrin molecules. So, but just even the copper number variation affects your risk of atopic dermatitis.
Very simple question. Could you put Filagrin in a topical and apply it externally? And the other, Mike Weiss for years has always used stuff called acid mantle cream as a topical therapeutic. Frankly, I hadn't heard that term again until today.
Yeah.
Is that still a commonly used topical therapeutic? And it obviously fits the bill.
Yeah. To your first question, I don't know about Filagrin products. As far as if I don't think they're commercially available. I don't think they've been designed yet. I don't know the stability of the molecule, whatever. So, but I think the goal is to target Filagrin in these patients, because whether or not you have a mutation or not, increase in Filagrin content and see it might have some beneficial effects. From the acid mantle, I didn't know about that either until a patient brought me in their jar asking for a refill, and I didn't know how to refill it. But as I read through this, I think that some in the dermatology literature does talk about using acid mantle type, those alpha hydroxy acid creams as a therapeutic strategy, again because it's been shown to increase, because of the pH modification and normal, I guess, more normalization to the acid pH of the skin, that then you increase ceramide production, and you may restore some of the barrier that may be there. And I didn't get a chance to look at that literature in full detail, so it takes some more research to see, benefits and risks. But yeah, I think that there is some therapeutic benefit to using those acid
Later in the year, we have a dermatologist doing the usual dermatology for allergists. Somebody try and remember to ask him that question.
Yeah. Well, along with Len's comment, there are two ceramide products. There's Episerum and Triserum that you can use to replace ceramide in the skin. But you mentioned that one soap that had a pH of like 3.7. Has anybody ever done any studies of that versus all the other soaps that at the side? 3.6.
Doesn't soap have to be alkaline to clean your skin?
I mean, that's the nature of soap. Yeah, that's why you see a lot of these. Yeah, so it has. But that's why they talk about that as being damaging to the skin, because it does. It kind of breaks down that acid, the natural protective acid, pH of the skin is altered by those soaps. So, yeah, I haven't looked at any studies I didn't see anything specifically with the avicide as far as use. Again, I didn't look at that literature.
And if you use the 4% lactic acid, what does that do to the skin pH?
As far as what the changes to, I don't know. I don't know a specific number. I just
the acid soaps, are they antibacterial and effective for whatever else we need to do?
I mean, I think that in general, the more acidic pH does alter our antimicrobial. That's kind of the benefit of some of them, and again, the benefit of the own skin's pH itself is antimicrobial. I don't know specifically if they are marketed as that at all. Did you have?
Trevor, it seemed this would be another situation where if you could identify an infant at birth with a defect, the care and treatment to prevent atopy would probably be helpful. I wonder if there are any dipstick finger blood or heel blood test things in the works in terms of early diagnosis of the genetic defect.
Yeah, I haven't seen anything along those lines.
Like for kid or other, but in a more to prevent the whole atopic cascade, if you could start with an infant right away and enhance barrier function or whatever it might be.
I think absolutely that if you can prevent, again, because of the association, specifically with asthma. Right. So if you can restore that barrier early on, prevent or control the degree of severity of atopic dermatitis, then maybe there's a role for it there. But yeah, I haven't seen anybody look at doing earlier screening.
We know that atopic disease is multifactorial. Has anyone looked at other genetic mutations that might be associated with Filaggrin mutations that might have a common cause or common mother cause?
So the one I saw was the caspase 14 enzyme. So that's important in the Filaggrin processing. And again, mutations in those did lead to an atopic dermatitis phenotype similar but not as severe, because that was kind of further downstream in the Filaggrin production. It affected Filaggrin processing to the amino acids versus the profilaggrin to Filaggrin processing. And so those, you got a more moderate phenotype with just some skin sensitivity and photosensitivity because you lost the natural moisturization factor from the Filaggrin breakdown. So yes, they have looked at other enzymes. That's the one I know about that I looked at. But I think some of the other whether it's in that, that associated gene in 1q21, if there's other things in that, I don't know if it's been fully looked at. I mean, Filaggrin's pretty recent. 2006, so this is all kind of a lot of information that's come out in the last few years.
It's uniquely in skin. You don't express it in any other tissues.
I think it is in the stratum corneum, so that's where I've seen that it's been expressed.
Has anybody looked at sensitization to different caspases as a function of the severity of the dermatitis?
I don't know.
A lot of the laundry detergents now have caspases in them, and they're getting applied topically to us all the time, so you just wonder if maybe there's a caspase line to this whole thing.
Yeah, I don't know about that, yeah.
Very nice talk.
Okay, yeah, thank you.
We should have one of those point counterpoint like the dermatologist had on one side. Dermatologist on the other side.
It would be useful to get some of their ideas.
You know, we had we're talking about doing some co-marketing with our